Dose calc at 3:10. So you'll have a little 10-minute break and then dose calc. All right. So we are going to start looking at drugs that affect the central and peripheral nervous system. And we already started looking at that in Farm, and I believe you were doing some of that in health assessment, or was that the eyes and ears? Okay, good. So things are, I'm hoping things are starting to kind of come together. So, so chapter 20 in your Farm book is called, look at that word, Anxiolytics. What do you see at the beginning of that? What word?
Anxiety.
Anxiety. So lytics is like break, things that stop anxiety, things that stop anxiety. In hypnotics, what do you think those are going to do?
Hypnosis. Knock you out.
Make you sleep, right? Kind of, the root, like hypnosis. It'll make you sleep. So that gives you an idea of what we're looking at here in this chapter. So here's the learning objectives that are a little bit more than what you had in the outline. So you're going to define states that are affected by anxiolytics and hypnotic agents, and then discuss the use of analytics and hypnotic agents across the lifespan, like adults and elderly. I mean, right off the bat, what do we know about elderly and pharmacology? Yeah, they don't process their meds, so the half-life may need to be, or the dose may need to be cut in half or less, because the half-life is longer in the elderly. So we can really overdose these people in the elderly. So what do you think, for things that are going to make them like hypnotics and anti-anxiety drugs, what do you think we're going to watch out for?
Orientation.
Overdosing, which might look like what? What was that? Drowsiness, like they're going to be too drowsy, too sleepy, right? We're not going to be able to wake them up. And a little bit more on that later. So, of course, the therapeutic actions, indications, pharmacokinetics, contraindications, adverse reactions, drug and drug interactions of these meds, and compare and contrast the prototype drugs of each class. And they're in your outline, and I'm just going to talk about the drugs that are in your outline, okay? So, outline the nursing considerations and teaching. So in the PowerPoint, I don't have it written in the PowerPoint what you're going to do, but we're going to look at the side effects and talk about what do you think the teaching's going to be for this? What do you think you're going to be monitoring for, looking at side effects and adverse reactions and contraindications? And then I'm going to have you go to the book and do those little clinical scenarios on your own and make that connection, okay? As you're doing them, if you don't feel like you've got it down and you don't understand, please email me. I'll be happy to help, okay? So we want you to do a little bit of this on your own, but I'm going to be lifting that up in class as we see those different side effects and adverse effects and things. So let's talk just about our neurotransmitters. This is just nice to know, to understand the needs to know. So we got acetylcholine. It communicates between nerves and muscles, and that's the one that causes us to move. It's the one that helps us physically move. Where we have norepinephrine and epinephrine, they're the cats, the two cats, meow, they're the two catecholamines. And when are they released? During what? Sympathetic fight or flight, right? It's when our heart rate goes up and our pupils dilate and our bronchioles open up, bronchodilation, so we can breathe more. We've all felt that when, maybe we've had a near-miss car accident or something like that. You're like, whoo, your heart starts beating. Dopamine, involved in the coordination of impulses and responses, and that is the one that, again with the movement, and we talked about Parkinson's disease and how if we don't have dopamine, we've got those tremors because it allows the acetylcholine to be more active. So, all right, just to review some of our neurotransmitters. And then we've got something called GABA, aminobutyric acid, inhibits nerve activity and is important in preventing overexcitability or stimulation such as seizure activity. So this is going to be important when we're going to also do a whole segment on seizure medications. And So the words like inhibits nerve activity is important in preventing overexcitability of our nerves, okay, or stimulation of nerve activity, okay. Now serotonin, you might have heard of this. It's that thing that's important to keep us, awake and sleep, and in preventing depression and promoting motivation. That's why people take the serotonin receptor medications when they're depressed. So just a little bit of our neurotransmitters here. Questions so far? All right, so states affected by anxiolytics and hypnotic. So anxiety, of course. Most of us have felt that. Tension, nervousness, apprehension, fear.
Every day.
Unpleasant reactions to stimuli. That can be, think about PTSD. People who've experienced trauma, soldiers, nurses have a lot of PTSD. And so a certain noise or a sound can just trigger this fear. And they're actually technically safe, but they feel fearful because they heard a noise or saw something that triggered them. Sedation, loss of awareness in reaction to environmental stimuli. That's just, not being, and some of you might have seen this at clinical. My group were in a neuro unit, so we saw some people who were really out of it in our clinical group. So we were trying to wake up and stuff. And hypnosis. This is extreme sedation, resulting in further CNS, depression, and sleep. So this is a little bit more extreme sedation. Now this is effects in the lifespan, and I just want to lift up, pretty much, bless you, talks about the alternative ways we can treat sleep, a lack of sleep, because the hypnotics are usually given for people who can't sleep very well, and so back rubs, meditation, a bedtime routine, things like that, warm baths, try to help them sleep. And then we always want to, of course, with a lot of these meds, watch liver or kidney function, and watch out for pregnancy and lactation with some of these drugs, because it can make the baby sedated, right? It can sedate the baby. Older adults, we've also talked about, that can cause deeper sedation. Now, dizziness too, and hallucinations in the elderly. It can actually make them, you've got an elderly person that's anxious, and you give them this drug, and now they think they see ants on the ceiling, and they're freaking out. So now you've got a more anxious elderly person, right? So it kind of can overstimulate that. Of course, liver and kidney function, that's pretty common that's how drugs are usually filtered out of our body. And we always want to teach them other non-pharmacological ways to help them sleep. So, all right. Now, let's talk about the drugs for anxiety. The drugs for anxiety are benzodiazepines. You might have heard of people call them benzos. So a nurse might say, oh, we need to get that patient some benzos, So benzodiazepines are the drugs we usually give for anxiety. So what does it do? What's its action? Acts on the limbic system of the reticular activating system. So RAS is reticular activating system, and that's that kind of part of your brain stem and part of the deep diencephalon of your brain that helps you stay alert. It keeps us what they call arousal, like I'm alert, I'm oriented, I'm awake, and I'm interacting with my environment, right?
Is it emotional too?
It can be emotional. It can be emotional. A reticular activating system, yeah, the limbic system could be emotional because we've got our amygdala that has a lot to do with our emotions too. And that's kind of all part of that, deep part of that brain too. So these meds make GABA, remember we talked about GABA, more effective. So it inhibits that excitatory cells. It inhibits those excitatory neurons. So do you think we can give this, we can also give this for anxiety, but if it inhibits excitatory neurons, What else could we give it for? What other disorder?
What is it,
Well,
Parkinson's?
not ADHD, not quite. What did you say? Like seizures. Yeah, seizures. Yeah, we're gonna see these meds again in seizures. So it's gonna cause interference with that neuron firing because it's gonna inhibit it. We're not real clear on the exact mechanism, but we know it makes GABA more effective. So indications vary by specific drugs. So anxiety, alcohol withdrawal, panic disorders, restless leg, the people that bounce their legs, restless leg. And then the seizure disorders and people who have insomnia, which means can't sleep. So, so when GABA binds, and this is benzo binding, it amplifies the neurotransmitter GABA, which means it calms it down. I'm just looking at my notes. Okay. Now, benzodiazepines are a controlled substance. So if you're pulling this out of the medication room, what do you got to do before you leave? You have to count them.
Mm-hmm.
So if Mr. Smith is getting one benzodiazepine, and there's 20 in the packet, you take one, you have to get one for Mr. Smith, and then you're gonna count, okay, now there's 19, then you have to put 19. You have to type 19 in the computer on the medication administration computer there, whatever it is, Pixis, MAR, whatever we call it. And then at the end of the shift, the day shift and the night shift charge nurse count all the narcotics and benzos to make sure it's correct, and you cannot leave unless it's correct. And if it's incorrect and they suspect anything, you're getting a drug test, a urine drug test. So, all right, benzodiazepines that you need to learn that are on your outline. So Xanax, we've all pretty much maybe heard of Xanax. Now I'm saying Xanax, so that's the common name, but on your exam and on NCLEX, you're gonna have the generic. Alprazolam. Alprazolam is Xanax. And this one is given for anxiety, panic attacks. So, I mean, it's a pretty common drug. A lot of people are on this drug for anxiety. Now there's clonazepam, and again, panic disorders, restless leg syndrome, and seizure disorders, okay? Now, we need to monitor for suicide ideation. So now this is where we're going to talk about, I didn't put it here, but I need you guys to write this down. How do we assess for suicidal ideation? We just say, do you feel like hurting yourself? Yes or no, And what happens, these drugs, make the patient feel a little bit better sometimes, and then they have the energy and the thought process now to carry out the suicide, okay? So it can be dangerous sometimes. So they always usually do when you go to the physician and they know you're on these drugs, they usually hand out a form and you do a questionnaire. So to see if you're, most people I think are pretty honest. So of course, liver issues and our blood counts. If they're on this med for a long time, their white blood count, red blood cell counts can be off. So these are things we're going to be monitoring for. Now the good old-fashioned vitamin V, Valium, which is diazepam. So you need to know it is diazepam. So this is really good, again, for anxiety and alcohol withdrawal. When patients want to quit alcohol, alcohol numbs the brain. It just numbs the brain. And if they quit cold turkey, the brain has gotten dependent on that alcohol to numb it. And so now it's not numb anymore. So now it's overstimulated. And these patients who are in alcohol withdrawal are at risk for seizures. And they're incredibly anxious and disoriented. People can die from alcohol withdrawal. And sometimes we can give them diazepam to calm those neurons so they don't have seizures, and also it calms them down because they're very anxious and they're confused and restless, things like that. It's a wonderful muscle relaxant. A lot of people might take diazepam with a painkiller, especially if they've got like cluster headaches or any kind of pain that has to do with muscle spasm. They might give them diazepam to help with that. So it would be adjunctive to other pain meds. Even though diazepam does not have anything to do with pain, it'll relax the muscles. So, all right. I used to give it, so we would give ibuprofen or, ibuprofen sometimes to our patients, and then we would give them Valium with it. And especially the ones that had the spinal surgery, because they would have a lot of spasms. So they weren't all knocked out with narcotics, and the benzodiazepines, they make them sleepy, but not too sleepy. Depends on the dose. Preoperative anxiolytic. So they might have the patient take this the night before their surgery, just because it's scary to have surgery, right? It can kind of calm their nerves before surgery. Now, taper after long therapy because they can have withdrawal. They can get dependent. Because these are controlled substances, there's dependency. So taper because they can have withdrawal symptoms, which could be seizures. Okay. All right, so those are the ones on your list. So let's talk a little bit more about the pharmacokinetics. So it is well absorbed in the GI tract. Peak levels achieved in 30 minutes to 2 hours. So they'll start feeling relaxed, hopefully, or muscle relaxed, or relief of their anxiety. Lipid soluble and well distributed throughout the body, crosses the placenta and human milk. So this could make a baby sleepy, right? A baby in utero sleepy and not, move around a lot. It could damage the baby. It can cause dependency in the baby. So it can be metabolized in the liver. So what are we going to be checking? Liver enzymes, right? Liver enzymes. And then excretion is through the urine. So we're going to check liver enzymes when they're on these for long term. So benzodiazepines, the contraindications and cautions. Anybody's allergic to it. It can induce psychosis in some people. It can cause something called acute angle glaucoma, which is an eye disorder that can be that can damage the eye and cause blindness. So we're going to learn a little bit more about that later. It can cause shock. They can go into coma. One time I gave an elderly man, he had broken his neck, and elderly people can have osteoporosis. He was in a car accident, and that whiplash caused him to break his neck. And he was still moving, but he had a collar on. He was supposed to lay completely flat. Of course, this happened at like 2 a.m. or something. So I came on day shift, and we had to do an MRI. And he wasn't sitting still, and he kept sitting up, and I'm like, no, you have to lay down, because if you move, you could become paralyzed. Because he did break his neck, but he didn't have any damage to his spinal cord. And he was confused, and I think he was having some alcohol withdrawal. And the doctor said, we'll give him, a benzodiazepine. And I did. I gave him the appropriate dose. And he went out to the point he was breathing like 10 a minute. And I was freaking out. So I'm like, I did this. I gave him, and he was like, it's okay. I told you the dose to give. And it wasn't an exceptionally large dose. It's just it was elderly. And I think, and he just we had to intubate him. We had to put a breathing tube in and put him on a ventilator. But, okay, just making sure it wasn't like a fire alarm or anything. The coma is a scary thing. Now acute alcohol intoxication, the alcohol and the benzos will have a synergistic effect, and it can really, because alcohol can make you sleepy, right? So it can do that. We don't give it in pregnancy, and use caution in older adults. I'm sorry that got kind of knocked off there. But use caution in older adults. So we've got addiction, withdrawal symptoms, safety. They can fall because it makes them dizzy. Suicide risk. The cognition can be off. Their thinking and it can be addictive, overuse. So usually, the benzos are usually not like the first line for anti-anxieties. So let's look at the adverse effects. So you can see, like I've kind of mentioned, sedation, drowsiness, depression, lethargy, blurred vision can be the glaucoma, sleep driving. Is that dangerous? And so it's almost like sleepwalking, but they're like literally with their eyes open, but they're not with us. They're driving still, but they're not aware of their surroundings, so they can hit things and get car accidents, right? Headaches, they can have an apathy, like a really flat kind of like whatever kind of affect. Lightheadedness, and that can be a risk for what? Falling, right? Amnesia, which is what? Just forgetting bits of your life, right? Confusion, they can have these things called mild paradoxical excitatory reactions. I had a niece who went on something like this, and she said, oh my gosh, it made me like more anxious. And also it can make people have these extra paradoxical movements sometimes, like with their tongue or like these movements sometimes. GI conditions, so like dry mouth, constipation, nausea and vomiting, because it can slow down the gut. Cardiovascular problems, like with circulation. Hematological conditions, so we talked about the red blood cells and the white blood cells being decreased. Genitourinary effects, like the urinary retention, like they don't pee all their urine out. Loss of libido, and changes in their sexual functioning. If it is given by injection, they can have reactions to it, and then of course withdrawals if they stop it suddenly. So like with the injections, they can get like phlebitis, and thrombosis and things like that. So teaching with the withdrawal, teaching. Let's write this down, teaching. If someone's going to be, they've been on this medication for a while, we need to tell them they cannot abruptly stop the med. They need to wean it off. They need to wean it off. Okay. Should be tapered slowly. Should be tapered slowly or weaned off slowly. Do not abruptly stop the meds, because it can cause withdrawal. Which can be like headaches, vertigo, nightmares, and severe seizures. Because remember, it's calming, or it's stimulating GABA, which is calming the neurons, and now you're not taking it anymore at all. So now the neurons are hyperexcitable. Cause seizures. Questions so far? All right. So drug-drug interactions, increased risk of CNS depression when taken with alcohol. Like I said, they could just get more, they could go into a coma and just more CNS depression. May increase the effect when taken with cimetidine is something people take for, it's an histamine blocker. It's taken for GERD and peptic ulcer disease and gastritis. And it can increase the effect of these benzos if taken with cimetidine. And oral contraceptives and something called disulfiram, which is somebody takes it for alcoholism, and if they drink alcohol, it makes them really sick. So they take the med to avoid drinking alcohol, because if they do, they get really sick. So then it can decrease the effect of the benzos if taken with theophyllenes, which is for asthma, or like COPD, because for bronchospasm. So those are the drugs we really don't want to combine with these. Now, because, like I said, the man that slipped into a coma, that I gave an appropriate dose of a benzo to him, there is an antidote for an overdose or toxicity. It's called flumazenil. Flumazenil can be given if someone is overdosed on benzos. And like I said, it can be addicting, and people can get it off the street. So it's a benzodiazepine receptor agonist, so it's blocking all those receptors in the GABA receptor, and can be used to reverse sedation and other side effects of the benzos. So that is your antidote for benzos, flumazenil. Any questions on that? So side effects of the benzo, barbiturates, and other anxiolytics. So, I mean, this one, where's GABA? GABA, where are you? This GABA receptor is where the benzos increase that effect. So, that's what we're looking at in this. So let's look at those side effects here. Oh, I'm sorry. Site of action. I was like, why is this picture here? Sorry. Site of action, is the GABA, like I said, which we already kind of went over. I apologize. So benzodiazepines of barbiturates, which we're going to get to in a little bit, and other anxiolytics. All right. So let's look at nursing considerations for patients who are receiving benzos. So this is where I'm going to have you go on your own study on page 348. Is all about assessment, nursing, planning, and intervention with rationale. And they complete the critical thinking scenario on benzos on page 349 to 350, because it goes through what you need to monitor for. So let's kind of think about this after we've just taught. And you can fill in the gaps with this, doing this on your own. So it's going to cause sedation. And they could slide into a coma. So what would you want to do frequently with someone who's on benzos if they're in the hospital? Yeah, check for their alertness, which is like a neuro exam, right? You're going to do frequent neuro exams. What other risk factor are you going to screen for? Depression, which can lead to suicide risk. Yeah, that's suicide precaution. Very good. And we talked about certain blood work that might change. Yeah, the white blood cells, the red blood cells, and also it's going to be filtered out by what organ? The liver, so we're going to check those liver enzymes, right? And you're giving them benzos for anxiety, so you want to say, how you feeling, right? Are you feeling less anxious? Tell me about how you're feeling. Are you actually not being triggered by things, or, I mean, that's our goal, right? We want to give this to help them reduce their anxiety. Okay. And also assess that they're actually feeling better with their anxiety. That's the point. Of course, with these meds, there's usually some type of therapy going on, like talk therapy, psychotherapy, things like that, so that they can work through some of their issues and hopefully maybe wean off these meds. That would be the goal, to wean off these meds. Okay. So let's do a question. I'll have you give me your fingers. A patient presents at a clinic with symptoms of restless leg syndrome. Which medication should the nurse expect the physician to prescribe? 1, 2, 3, or 4. Restless leg. Okay, it's actually B, clonazepam. Did you notice something about the ending? Are they Pams and Lambs? They're your Pams and Lambs. So your Pams and Lambs are benzos. Pams and Lambs are benzos. So the ending helps. There's even, I should have put a meme on here. Something about all nurses love Pam, because it calms their patients down, right? The Pams. So, anyways, so this is the one that's indicated for the restless leg. A lot of people can't even sleep because they're constantly shaking their legs in their bed. It helps them. Okay, so that's benzos. Benzos. Questions? All right. So now we have something called barbiturates. A little bit different. Let's look at barbiturates. So it's a central nervous system depressant. and they depress the cortex, so they're more central nervous system. The RAS system, so this is where, you know, the RAS system is down here in the brainstem, and also it shoots up through the limbic system. And then it inhibits neural impulses conducted in the ascending RAS. And then it depresses cerebral cortex. This is all this bumpy stuff, is all the cerebral cortex. And it alters cerebellar function. So what are we gonna see with that? Yeah, issues with gait and maybe doing that finger to nose thing. They'll be like really uncoordinated. They'll be uncoordinated. It does depress motor output. So they're not gonna be quick to pick up stuff. They'll be a little slow. And they'll be, when you go to clinical, you might see these patients on there, they'll be like, they'll just be a little bit slow. The actions are gonna cause sedation because it depresses the central nervous system. So it's gonna cause sedation, hypnosis, ooh, anesthesia, what's that? Sleep, yeah, it's what so do you think nurse anesthetists are given this during surgery? Yeah, absolutely. In extreme cases, coma. So there you go. Any questions on the mechanism of action? Okay, so when do we give this? Relief and signs and symptoms of anxiety, not the first line treatment. Sedation, if we need to sedate our patient. Treat them for insomnia, pre-anesthesia, like I said. Treatment of seizures, and this is where I've seen pentobarbital. This is the drug on your list that goes with this class. Barbiturates is a class, and phenobarbital is the drug underneath barbiturates. And I have seen, in my experience as a neuro nurse, we gave this as an IV drip on people who were having constant seizures. And then we call that status epilepticus, where they're having constant seizures. Because usually seizures last a minute or so. They shouldn't be lasting for hours. And when they do that, we have to put them on something that completely depresses the central nervous system, just stop those seizures. Because it's incredibly dangerous. It can cause brain damage for them. So that's my experience with phenobarbital. Parenteral forms may be used to treat seizures. So we gave it IV drip on a pump. So
that's the main indicator would be for seizure.
well, I mean, like I said, the parenteral form is used, like the IV drip form is used for seizures, and that was my personal experience as a neuro nurse. So it can be used in all these other things too, but I'm just telling you my experience. Okay, so sedative hypnotic, control of seizures, it's pre-anesthesia. We again want to taper this gradually, because if we give this drug and it depresses the CNS, we have to slowly wake up the brain again. We have to reconnect the brain again. So we always want to wean that off and give slowly and monitor any injection sites. So, absolutely. Okay. So barbiturates, they're pharmacokinetics, they're well absorbed. They reach a peak in 20-60 minutes, which is really great. Metabolized by the liver, straight in the urine. So we're gonna make sure we're looking at our liver enzymes, right? It can cause hepatic and renal dysfunction, and if they do, we need to lower the doses. What labs do we monitor for our renal function? Yeah, BUN and creatinine, BUN and creatinine, good. It can cross placenta, enter human milk, so it will sedate the baby in utero and also within the breast milk. So we don't want to do that. Not recommended for pregnant women and women who are breastfeeding. Now, contraindications and precautions. So again, the allergy. Previous history of addiction. These drugs are highly addictive because it alters their central nervous system, so some people kind of like that. And they're addicted to sedative hypnotics. Usually, patients who are addicted to this, they have underlying maybe mental illness and or severe anxiety issues that are undiagnosed and not treated, right? So these people need to get, the appropriate assistance. They can have the latent porphyria, which is a type of urinary, well, no. It's a type of like psychosis. They believe King George had it years, back in the 1700s. Hepatic impairment and nephritis. What's nephritis?
Inflammation.
Like kidney inflammation, yeah. Now, respiratory distress and respiratory dysfunction, when we, in neuro ICU, when we gave this for our patients who were having constant seizures, or what we call status epilepticus, we had to intubate them and put them on a vent because it literally knocks out the respiratory system. So we had to put them on a ventilator to save them from the brain damage from their seizures. Of course, we don't give it in pregnancy, and patients who have chronic pain, we want to watch them, seizure issues, and hepatic, cardiac, or respiratory diseases, because again, cardiac and respiratory, it can slow everything down, it can cause decreased liver function, and this is not the first line drug for someone that has seizures, okay? Again, these are so powerful CNS depressant that it's not the first line drug for anxiety or seizures. Okay. The thing is, for chronic pain, it can mask the symptoms of those paradoxical excitement, because it's a CNS depressant. It can cause withdrawal and more seizures, and exactly. So their adverse effects, so let's look at this. So the adverse effects are going to be more severe than the other types of sedative hypnotics like the benzos. Like again, it's not the go-to drug for anxiety. It's not the first line drug for anxiety. And again, our CNS depression signs and symptoms. So make sure you know these, because I'm going to constantly say signs and symptoms of CNS depression. So it's going to be drowsiness, somnolence. That's just being like sleepy, right? Lethargy. Ataxia is the movement disorder, not being able to walk or move very smoothly. Vertigo, what's that?
Yep, everything spins.
Yeah, the room's spinning, like the room is spinning. A feeling of a hangover, thinking abnormalities, so cognitive issues, paradoxical excitement, so some of those movement of the tongue and rolling, these kind of like bizarre little random movements. Anxiety, so we're giving it for anxiety, but it gives anxiety. And hallucinations, like I was mentioning also with the elderly with benzos, because it can change perceptions. And GI signs and symptoms, nausea, vomiting, constipation, or diarrhea, and epigastric pain. Now cardiovascular symptoms, it's going to slow everything down. Bradycardia, hypotension, especially if we give it IV, and syncope, what's that? Fainting. It's actually fainting. Syncope, it's fainting when the patient doesn't have blood to their brain. It's usually caused by hypotension because they can't get the blood to their brain. Right? Yeah, syncope is fainting, passing out, because the person doesn't have blood circulation to their brain. So you can have the hypotension can cause syncope. So serious hypoventilation, like I was saying, when we gave the phenobarbital, we had to put people on the ventilators. So it can cause laryngospasm as well. Laryngospasm is the throat closing up. Hypersensitivity reaction, so again, a lot of these are going to be rash, serum sickness. Stevens-Johnson syndrome is when their skin, it can fall off. That's like the severe form of it. Again, the Steven Johnson syndrome can be fatal if the skin falls off. Then you get infections and die. Okay. So now drug-drug interactions. So anything that's gonna increase that CNS depression. So alcohol, antihistamines. Doesn't Benadryl make you sleepy? That's diphenhydramine, which is an antihistamine, and other tranquilizer drugs. Altered response with phenytoin, which is a seizure medication, which we'll talk about later. MAO inhibitors, they just don't give those out anymore. They're terrible drugs. Increased serum levels, so it increase the effect. And decreased effectiveness of some drugs such as oral anticoagulants, DIDs, tricyclic antidepressants, corticosteroids, and oral contraceptives. There's a lot of drugs you can't take with oral contraceptives. It makes them ineffective. So, all right. So this is your like drug card. So phenobarbital, that's the one on your list again. Sedation, short-term treatment of insomnia, long-term treatment of tonic-clonic seizures, or some focal seizures, and emergency treatment of convulsive or seizure episodes, and the pre-anesthesia. Like we said, it inhibits conduction of the ascending RAS, depression, we already kind of went over all that. So you can give it oral, IM, sub-Q, or IV. And then there's all the adverse effects we just talked about. So this is like your little drug card. So nursing considerations. Again, you're going to read the nursing considerations on page 352, 353 on your own. But we already kind of talked about that. So again, what kind of assessment are you going to be doing frequently? A neuro assessment, right? Also maybe a muscular, gait, see if they can move, like a neuromuscular or musculoskeletal assessment to see if they can move properly. We're going to do what labs? It affects what organ?
The liver.
Yeah, the liver and the kidney. So liver enzymes and bun creatinine. We might put them on what kind of risk factors?
Suicide.
Fall risk. Yep, absolutely, because it makes them dizzy, vertigo, all that stuff. Fall risk. Yeah. So we can see here chronic use can cause, changes in alertness, decreased functioning, irritability, and memory loss. So assess for those side effects, as they're taking these meds. What were the GI side effects? Nausea, vomiting, either diarrhea or constipation. Good. So think about all those side effects and what you're gonna assess for. Bradycardia, hypotension. So if you've just given somebody some phenobarbital and you're getting them up out for the first time, what might you want to do? Might want to assess before you get them up. What? Yeah, the blood. You're going to do orthostatic blood pressure. So a blood pressure and heart rate laying down and sitting up, and of course you're going to want to be there when they stand to make sure they don't have a syncopal episode, right? You're going to want to put, what would you want to put on their finger for respiratory? Pulse ox. It might want to be continuous maybe instead of just every 4 hours, right? Continuous. Make sure the alarm's on. And look at the skin for those hypersensitivity reactions. So pretty much look at these side effects, and this is what you're watching out for. Nurses are a bit of a pessimist. We're looking for the scary stuff that can happen, and we're preparing for it. So that can give you an idea of some of the nursing care when you read this. All right, question. Is it true or false? The peak level of barbiturates occurred 60 to 90 minutes. 20 to 60. 20 to 60. Very good. All right. Okay, any questions on barbiturates? Yeah. Not necessarily, no. I'm kind of looking for, how it acts on the patient, and then what to monitor for and look out for in your patient, you know.
So no peak times for this.
What was that?
So like no peak times for that.
I mean, you need to know when it's gonna hit the patient, in general, yeah. So yeah, I mean, is it gonna hit them in 2 hours or is it gonna hit them in 10 minutes? You know, it lets you know maybe how often you need to be checking on them, right? So, all right. So other anxiolytics and hypnotic drugs. So the one that's on your list is a sleeping pill, Ambien, but it's zolpidem. So it is a pretty intense sleeping pill. All right. So short treatment for insomnia. So these are more, you know, hypnotics. So zolpidem is going to cause sedation and also treatment for insomnia. It selectively binds to specific GABA receptors, and they do not tend to bind universally to GABA receptors compared to the benzos or barbiturates. It's a little bit more selective. Again, it's metabolized in the liver, excreted in the urine. Zolpidem is given in a tablet, and or a metered spray is the dosing. Now, the big thing with this is sleep driving, and they'll be doing like complex things and without safety issues. I know there was a movie star that had a TV show, and she took this to sleep, and she was up in the middle of the night on social media just talking smack, and she lost her show because she was offending everybody. And she blamed it on zolpidem, sorry. But she lost her show and never got it back. Yeah.
I know in my class, she almost bought the health. And so we have a show that you can buy like animals online, and she almost bought the cow.
She almost bought a cow. That's so yeah, they do like, it's almost like they're sleeping but awake, and they're doing bizarre things. So, and this actor tried to apologize, but she never got her show back. She got kicked out. All right. So, but yeah, people tell me, oh, I just take an Ambien, and I'm like, that's kind of a powerful sleeping pill. So yeah. Again, this is from the book, Ambien, usually 5 milligrams PO at bedtime, up to 10. And they can do the spray as well. Special considerations.
Males and females.
Watch out for suicidal ideation. And also if they're gonna stop this med, they need to wean off, taper slowly. And they need to take it before bed. We don't want them acting like this during the day. Again, hepatic and renal impairment, check the liver enzymes and the bun creatinine. Now, the older people may react differently. They might get very anxious and restless with this. And so we might have to give them a lower dose, the elderly, like we were talking about earlier. All right. So let's do a question. You are admitting a new patient. Oh, you're just putting your check. I thought you were raising your hand. That's good. You're admitting a new patient to a clinic. A review of home meds indicate the patient is taking a barbiturate to help them sleep. The patient tells you that they are having problems with their visual and auditory senses. The patient wants to know what is wrong. What would be the best response? So give you some time to answer this.
There's nothing wrong with you just getting older.
It's a little wordy. Give you a few moments. So it actually is B. So it can be, they're actually having some form of adverse reaction. So nursing Conclusions related to drug therapy might include altered thought processes and altered sensory perception related to that CNS effect with the barbiturates. So. All right, any other questions? Yeah.
What's the barbiturates and with the
Is
Zoloft,
hypnotic
yeah.
or analytic? Or
some
analytic?
people just are working
Or sedative?
those like really weird
Are you sure?
reactions.
Yeah, it could be like a genetic thing. Yeah,
Yes,
it could be.
None of the women in my class can take sleep. That happens all the time.
Yeah, exactly. Sometimes it's a genetic thing. So yeah, Stephanie?
That girl, the doctor told me that it's not a hormone, that's why you take that pill and lay down. You really put the camera where you usually sleep. Because if you have anything with triggers, like some leaky paper, you're gonna have that. That's
They
why
could
I
act, it could be a harm to themselves or others. I mean, it would be a financial burden to buy a cow. You know. Yeah, cook things, burn things, yeah, so absolutely. So some people can take it and be okay. I think it is a genetic way they react to the medication. So.
Yeah, my mom sleepwalked across town.
That's terrifying. I mean, danger big time. All right, any other questions? All right, let's take a 10-minute break, come back at the top of the hour.